Good evening, everybody. Today, we will discuss an important topic, I think, which is very relevant to us as gastroenterologists, but it is also relevant to a lot of physicians, ENT surgeons, and overall in our practice of GI physiology that we routinely see these patients. It is also important from examination point of view for fellows who are going in for their boards, GI boards, and DM or DNB exams. So today we will talk of dysphagia and how do we approach dysphagia in a practical manner, in something which we can really relate to in our GI practice. So I will just share the screen and I will try to see if we can start our talk on dysphagia. So, hi, I am Dr. Zubindev Sharma, and I am a DNB gastroenterology, and I'm a consultant at Vedanta MedCity currently. And I run the GI physiology lab there, and we routinely see patients with dysphagia, and we routinely, evaluate them in an advanced manner to get the best outcomes for them and the best treatment guidelines. So to begin with, I think let's we just set the agenda. We'll try to define dysphagia. We'll try to classify it. We'll also try to see, what kind of associated symptoms that dysphagia actually comes with, what relevant clinical examination we have to do. After we have done a good examination, we also have to provide some testing for dysphagia. We have to understand that we live in the era of an evidence-based medicine, and so automatically we have to develop some testing protocols. And how do we utilize these tests to, identify our underlying cause of dysphagia and utilizing those guidelines for management and some more advancement, and finally we will conclude. So to begin with, I think as a gastroenterologist, as GI physiologist, we usually relate dysphagia to two common things. We when I see a patient of dysphagia, my first thought usually goes to malignancy, CI esophagus, or things like motility disorder like achalasia cardia. But what we have to understand is that these two are not the only symptoms that are there when somebody has dysphagia. These two are not the only reasons. There are so many reasons of dysphagia in the community, and patients who have neurological illnesses, of stroke patients, dementia patients, degenerative neurological disorders, almost 80% of them can have at some point of time dysphagia. And if you look at long-term care residents, you look at patients with COPD, in pneumonias who are on tracheostomy, head and neck cancer patients, post-radiation patients. So the context of this slide is that it is one of the most common symptoms. It's not something which you will see one-off, and it's not just related to CA esophagus or dysmotility. There are many causes to it, and as gastroenterologists, it's our job to actually help them out in all the spectrum of those cases. So our testing and our examination should be addressed to the clinical spectrum that we are seeing. If we are seeing a patient of neurodegenerative disorder with dysphagia, what we are trying to find out is there some reversible cause of dysphagia, something which we can find out worse, and if not, then can we provide some long-term nutrition to the patients by some other means. So actually our work is cut out if we really see these difficult to treat and difficult to identify patients. So before we go into the nitty and gritty of dysphagia, I think the first relevant point is we have to define what exactly do we mean by dysphagia. In dysphagia, we are classically telling that patient has a difficulty in swallowing. Other terms are like odynophagia, which basically means a painful swallowing. There's also a concept of a globus pharyngeus, which basically means that there is a feeling of foreign body sensation or fullness in the throat or esophagus without any clear anatomical explanation or physiological explanation. Now, this globus pharyngeus is a very common entity A lot of our ENT or otolaryngology colleagues, as well as GI colleagues, will see these patients on and off in their OPD. Till now, when we are defining this, there is no clear anatomic explanation, but there has been certain small studies which give an association of globus pharyngeus with certain anatomical structures. For example, there has been some reports which say that patients who have an inlet patch, they tend to complain of a globus symptom. Some authors have even done an argon plasma coagulation of those inlet patches, and have reported that there is some relief to the global symptoms, but this can also be at best a placebo response. So currently it's just considered as a functional GI disorder or a DGBI. There is no clear recommendation of doing any APC or anything, but that's a term which you will on and off encounter in your OPD. But for the focus of our discussion today, we will focus on dysphagia and odynophagia. So, when we say that, in our OPD as GI physiologists, we tend to put everybody into a dysphagia or dynophagia or a globus, but in practice, patients will actually say so many more words. They'll say something is wrong in my neck, something is coming back, I just can't swallow, I am vomiting when I am swallowing, something is coming back into my nose, there's a water brash. So all these symptoms patient will complain of. And for a patient, it's not easy to really sometimes explain what he is feeling. So what we as gastroenterologists have to do is we sometimes have to put all these terminologies that patient is coming up with complaining of into these terms and try to see if we can identify what is wrong and then test them. So before going ahead, I think we should just discuss types of dysphagia. This typing is purely for our understanding so that we can guide our investigations. There would be a significant overlap between this kind of dysphagia, but for our understanding, let's begin with something called an oropharyngeal dysphagia, where the difficulty is in initiation of swallowing. So a lot of patients who have tongue abnormalities, who have neurological abnormalities involving the tongue, who have palate abnormalities, can develop this oropharyngeal dysphagia. We have seen patients, kids particularly, who have been operated on for palate abnormalities, but they can still complain occasionally of dysphagia. Next important thing comes is something called the neuromuscular symptom complex. Now, this thing is something which becomes more and more complex because there is a lot of complex, muscle orientation involved for some way to develop dysphagia. So it involves all the muscles that are required in your pharynx as well as your larynx, where one area the airway has to close up and your GI tract has to open up for food to go through. And anything that disturbs this neural muscular complex will give rise to dysphagia. And a lot of degenerative disorders like Parkinson's disease or Alzheimer's disease actually affects this area. On the other hand, it can also be involved in certain structural abnormalities. Now, there is a correlation of structural abnormalities developing as a result of neuromuscular dysfunction in this area. Things like Zenker's diverticulum or Lammer's diverticulum or cricopharyngeal so bars. These are usually the result of high pressure at the level of UES because of neuromuscular dyssynchrony. So some authors have used an umbrella term called as a cricopharyngeal achalasia to define these abnormalities at the level of UES, but it's a lot more than that. It's not just at the level of UES. Almost all the muscles which are involved with swallowing can be affected. Now, moving down the track, I think esophageal dysphagia is something which, as us GI gastroenterologists, are pretty familiar with. We divide them really into intrinsic, extrinsic, and motility disorders, which I'll cover in the later slides. Functional dysphagia is something which I've already told you, something like a dysphagia, globus feeling, where there is nothing wrong, but it's possibly a DGBI. So let's first talk of the oropharyngeal and neuromuscular symptom complex. So we can usually divide them into neurological causes, myopathic causes, as well as structural or other causes. In neurological causes, we see a lot of neurological degenerative disorders like ALS or Parkinson's, and we can also see vascular disorders like stroke, autoimmune disorders like multiple sclerosis, and certain brainstem lesions which can give rise to dysphagia. In myopathic disorders, conditions like myasthenia gravis or polymyositis can also give rise to it. There are conditions like oculopharyngeal dystrophy, which can also present with dysphagia. These are progressive disorders where your patient, may be uh, heading towards more different forms of enteral nutrition, like a PEG tube or an FJ tube, when they develop it. As I said, there is possible a correlation between structural changes like Zenker's diverticulum or neuropharyngeal complex disorder, because it's actually common in elderly population. But there are other conditions like oropharyngeal tumors, xerostomia, in autoimmune disorders like Sjogren syndrome. Post-surgical and post-radiation changes are pretty common in GI practice to have dysphagia as well as mucositis because of drugs or radiation. So how do you evaluate oropharyngeal dysphagia? I think it's one of the most common forms. You can easily identify if there are associated features like there is a change in voice, or there is some neurological localization, or patient is already diagnosed with a case of neurological disorder, so it becomes pretty obvious. But the issue comes when the diagnosis is actually based on dysphagia itself, and dysphagia is a presenting problem. In those cases, you can still think of some disorders, like if it's a vascular event, it will probably be a sudden onset, dysphagia, which can sometimes happen with a lateral medullary syndrome or pica syndrome, whereas more gradual onsets will point, which are the more difficult ones to diagnose, will point toward something like myopathies or neuropathies. In esophageal dysphagia, I think it's something which we are more understanding, and where algorithms are more clear, are these set of disorders where you will have an intrinsic, extrinsic, or motility. In intrinsic, it's pretty common to have food impaction or foreign body impaction, particularly in cases of eosinophilic disorders. You can have a reflux-induced esophagitis or LA grade D esophagitis, a stricture, web rings, and malignancies, and infectious. In infectious part, one thing I like to really highlight is in patients who have COPD, who are on inhalers, having a fungal cause of dysphagia in the esophagus or a candidiasis is very, very common. And it's something which we should be, clearly looking for. And sometimes I feel it is missed as a diagnosis. In extrinsic causes, you can have some mediastinal masses or aortic aneurysms or vascular rings, which can also present as called the dysphagia lusoria, which can present as dysphagia. In motility, I think it's achalasia, which is one of the most well-known disorder, which we sometimes still miss, and I don't know that why we are still missing it, but we are missing it. DES, nutcracker or jackhammer. In some part of the world, there will be Chagas disease. And of course, systemic sclerosis. I think we've already published that dysphagia can be a presenting symptoms of scleroderma. And once you find those classical changes of absent peristalsis with hypotensive LES, we should always try to look for scleroderma in the relevant patient. So how will you go about it? History is one of the most important things. You have to identify whether the patient had dysphagia or odynophagia or both of them. What was the duration and the pattern? Was it an abrupt onset or a gradual progression? Is it a consistent every day, or it's an intermittent episodes? Is it progressively bad from liquid to solid or solid to liquid? What are the associated features like heartburn, weight loss, vertigo, coughing, change in speech, halitosis, or dry eyes? In the past, the patient gave a history of neurological illness, some recurrent pneumonias, radiation therapies. All this is relevant when you are trying to understand that why a patient has developed dysphagia. Now, in examination, I think the obviously we have to do the full detailed examination, but the most important things is your neck examination. If you can find some lymph nodes around the neck area, you will have a more solid diagnosis. An epigastric area, you can sometimes find masses. In patients who have large left atrium, you can have murmurs, and you should auscultate them at least once. And of course, without doubt, just without saying, that neurological examination is definitely a must when you are facing a diagnosis of dysphagia. Now, after we have done a relevant investigation, relevant history and examination, we of course have to test them. Now, depending on what kind of clinical diagnosis you have made, you will direct your testing accordingly. But in a nutshell, what are the tests available for all kinds of dysphagia to us? If your diagnosis is more towards an oropharyngeal or a neuromuscular complex dysphagia, I think the first two tests are more relevant, something called the video fluoroscopic swallow study or a nasopharyngoscopy or FEES. FEES would I think it's FEES, FEES. It basically means functional endoscopic examination of swallow. If your primary clinical diagnosis is towards esophageal disorder, the test that you might have to do is something like an endoscopy, which is a must, followed by a barium or a esophageal manometry, depending on your local available expertise. I personally feel that a manometry is much more detailed for dysmotility as compared to a barium swallow, following an endoscopy, because with an endoscopy, you have practically ruled out any structural causes. I think the next most important test would come as manometry. And if you have extrinsic disorder, of course, a CT scan or imaging of a chest is a must. Now, the question is when and where do you start? I think, as I said, the first thing is looking at your history, drooling or food spillage or repeated swallows to clear the pharynx, things like difficulty in initiating the swallow, those will look towards your oropharyngeal versus odynophagia or sensation of food getting stuck in the chest. All this will go towards esophageal disorder. And if it's a dysphagia to solids only or solids predominantly, though looking at a mechanical obstruction, if it's to both, we look at motility disorder. Now let me begin with for evaluation for oropharyngeal, dysphagia. Now, video fluoroscopy with barium cracker or a barium paste is something which has been done for years now. And in this particular video, you can clearly see a normal swallow versus an abnormal swallow, and you can see some aspiration going on towards the trachea in the abnormal fellow. This is one of the preliminary tests if you are going to evaluate on neuromuscular dysfunction. And I think this is most important, which gives you a relevant anatomical details or why this would be actually happening. Now, this video basically is showing you a patient of C. larynx who is post-radiation with dysphagia. And what they're trying to do is a functional endoscopic or a flexible endoscopic evaluation of swallowing. You can see the vocal cord, you can see some asymmetry, you can see some changes here, some food material. The patient is trying to clear it again and again, but it's not able to clear it. It's still there. Patient is not able to swallow it down to the esophagus, and this leads to some amount of aspiration. And he is doing some repeated clearing or repeated swallows to clear this available food material which comes to his uh, throat. So this is one of the very important tests which can actually tell you whether patient has a transfer dysphagia or not. And this video is classically showing some amount of transfer dysphagia. Now, sometimes, a patient is not really, mobile, and we do this small bedside test where we give some colored food to the patient, and they try to swallow it. We do some aspiration, and we can see some color in the lungs. That also tells me that patient is aspirating. So these patients are obviously not going to be fed orally as of now. They have to be dependent on trials to feeding. So this is something I routinely do, is something called as a high resolution pharyngeal or an esophageal or a UES manometry, where we in the first image you can clearly see that there is some amount of pharyngeal swallow that is happening around here. These are from the pharyngeal muscles called as the pharyngeal stripping wave. And in this case, which basically a patient had 9/10 no palsy, you can hardly see any of the contractions happening in the pharynx. So now the problem with HRUES is that classically you are dependent on a solid state equipment to really do a UES manometry, but there is now increasing experience and increasing data of using a water perfused equipment to do this manometry. We have been doing it using a water perfused equipment by reducing our flow rates, bringing up the catheter to the level of the UES, where The sleeve part actually then correlates to the UES where the maximum number of sensors are. The other problem with UES manometry is that it's not yet as standardized as it is for the esophageal or LES manometry. We have the Chicago classification available to us and Chicago algorithm available to us for diagnosis of esophageal disorders. For pharyngeal as well as for UES, disorders, it's still more of person-based experiences. There is no clear standardization available, although attempts have been made to standardize these manometry also, but because of the complexity of the equipment involved, I think it's still not very standardized. Now, endoscopy definitely the must. This endoscopy shows you a case of ecclesia cardia where there is a very mild dilatation of esophagus, but you can see there is some resistance to pass of the LES. So this is of course very important, but it's something which has to be appropriately done. And of course, endoscopy will pick up a lot of things like herpes, esophagitis, reflux strictures, malignancies, eosinophilic, disorders, food impaction. All these things can be clearly identified. Now, barium swallow and gastrographin swallow is something which we all routinely do. On the right side, you can see a patient of suspected ecclesia and dysmotility. You can see some tertiary contractions. You can see it's still emptying out, but there is some problem. On the left, you can see a classical case of distal esophageal spasm, and this is something which I think is very important for these set of disorders to do an appropriately done barium or a gastrographin swallow. Moving on, I think esophageal manometry for esophageal disorder is the gold standard for diagnosis. This is a case of a type 3 ecclesia where you can actually see on a 3D reconstruction on the animation on the right side that how patient has almost closed his distal esophagus and LES and food and nothing will go through while patient is swallowing, and with time it will actually open up again. So a properly done esophageal manometry, LES manometry is a must, and there is no both for evaluation of dysphagia as well as after an intervention of dysphagia. If somebody has a patient has repeat symptoms or you're planning for a redo interventions, I think there is nothing better than doing a manometry to really identify your pathologies. There's a whole Chicago classification available for esophageal disorder. I'm not going to go into the detail of that, but if somebody who wants to read, I think Chicago algorithm and Chicago 4 classification is something which we all now should be following. Now, just a brief touch on which test to do for different kinds of peristalsis. I think the primary peristalsis is basically dependent on a swallow, and to check that, you should do a high resolution esophageal manometry. When you were talking of a secondary peristalsis, when basically meaning distension, which is induced by distension, there is something called as an endoflip, which is now available. Again, this is a new kind of a test, new for Southeast Asia or East Asia, but it's actually been there in Europe and US for some time. And there is a lot of experience now coming in for endoflip, including for motility disorders, eosinophilic disorders, and using this for pyloric distension also for cases of gastroparesis. The 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 it's a large topic to really tell you in detail right now, but just remember that for secondary peristalsis this is one of the only available tests that is there. For tertiary peristalsis, which is a spontaneous peristalsis, it's more of I think still based on imaging on gastrography. As that I said that high resolution esophageal manometry is a must, and you can pick so many different kinds. All these images are basically from motility disorders, right from jackhammer to oculopharyngeal dystrophies to absent peristalsis to infective motility to multiple rap. So there's so much data available now of use of HREM for motility. This was the case of absent peristalsis. You can see there is nothing, there is no contraction happening in the esophageal body. There is a hypotensive LES, and this looks towards as a case of scleroderma. And we did a water immersion, ice immersion test, you can see some areas of partial Raynaud's phenomena happening and some redness happening, bluish tinge on the tips, which gives you what the diagnosis of systemic sclerosis. Now, GERD is something which is very, very common, and I think it's underdiagnosed as a cause of dysphagia. But you can see in this reflux testing, impedance testing, that the whole of the esophagus, right from Z6 to Z1, the whole esophagus is exposed to pH of less than 4. This is a classical case of a truly erosive, I mean, truly reflux esophagitis, acidic, this thing reflux. And I'm sure if you do an endoscopy in it, you will find some amount of changes of erosions in them. Now, moving on, I think the uh, imaging of the mediastinum is something very important. You can do an EUS if you have if you have a subepithelial lesion, lesions like leiomyomas or lesions like duplication cyst as a cause of dysphagia. This is a leiomyoma and this is a duplication cyst. You can also do a mediastinal imaging for various structural lesions as a cause of dysphagia. Endoflip, this is how endoflip actually looks like, and as I said, it's beyond the scope of this talk to talk of flip panometry, but this is how actually it looks like. There is a certain protocol involved on how you should test them. As of now, its indications are pretty clear in suspected borderline cases of EJJ outflow obstruction, or in cases of pyloric functional stenosis where you are contemplating GPOM across any anatomical, anastomosis where you feel that it is functionally narrowed. You can utilize endoflip for its evaluation. Uh, what next is that we can sometimes combine two things together. We can combine both barium swallow as well as a manometry to get something called as a video fluoromanometry. And this we routinely now do is available with us to utilize, where you can combine both modalities together and possibly get a better delineation of your motility disorder. Now, just to close in now, I think if you have a suspected oropharyngeal dysphagia, when the specific diagnosis is not very, it's pretty clear, you can directly go for that focused approach. But in cases where it's not clear, you should think of what can go wrong. If it's a structural, anomaly, you do a good nasopharyngoscopy or a FEES. If it's not, you can think of video fluoroscopic barium. Now, these both can interchange depending on difficult or typical cases. Sometimes you may do nasopharyngoscopy first, followed by a barium, or vice versa. This can happen. But if it's a visible abnormality, of course, you will take a biopsy. If not, you think of a UES pathology. In UES pathology, then I think the first thing you should do is a UES manometry. Moving on, if in cases of esophageal, dysphagia, again, if you have a specific diagnosis, you do a focused workup. Otherwise, in my opinion, I think an endoscopy is the first step that you should be doing. In sometimes when there are no red flags, you can possibly skip it, give a trial of PPI, and then do endoscopy. But I think in absence of these red flags, you should still do an endoscopy. If there's something which is known, you know there's a stricture or something in the you have previously done some dilatation, you want to still evaluate, you can do a barium and come back to your EGD. But I think EGD is the central point of your testing if you think of an esophageal disorder. Followed by, again, you divide them into intrinsic, extrinsic, or motility. For intrinsic, you take biopsies. If everything is normal, you can possibly, now this is a bit, arguable. You can do a barium first or a manometry first. I prefer to do a manometry first. But if it's an extrinsic compression, I will do an imaging. But ultimately, if everything is normal, it comes down to the manometry to give you the diagnosis. And I think after endoscopy, I think manometry becomes a central point for your difficult cases. If everything is normal, you start thinking of functional dysphagia. So to conclude, ladies and gentlemen, I think dysphagia is a common presentation with in wide variety of disorders. History-based algorithmic approach is the most efficient in your diagnosis. Investigations will only confirm what are you clinically suspecting, and investigations will also help to choose what is the best management strategy. So, for dysphagia, remember that it's not just esophagus, it can be so many more things can go wrong. And I think a relevant history examination should definitely guide you on what to do further. So, something for the future, something called as an esophageal distension plots. I think this will come in a few years, possibly adding to our currently available armamentarium for evaluation of dysphagia. So thank you very much, and you all are welcome to our lab. And I hope that this lecture helps you. So we will bring out more academic educational videos on various topics, and we hope to see you there. So thank you very much, and thank you.